Good evening. My name is Kim Grady, and I'm a student of Purdue Global. I am in the Psychiatric Mental Health Nurse Practitioner program, and today I will be discussing caring for the mental health needs of special populations in primary care. This is for class MN660. Our first special population will be the elderly, specifically focusing in on grief from loss of spouse. Spousal deaths, especially among the elderly, have a wide range of effects, including decline in areas of health, mental, behavioral, and socioeconomic status. According to the 2019 American Community Survey, nearly 1.2 million adults over the age of 60 have lost a spouse in 2019. Also, with that loss comes a loss of household income, which is approximately 5,500 or more per year, leaving a lot of elderly people homeless or needing to go live with their children or another family member. The diagnosis and criteria DSM-5 for this grief loss would be persistent complex bereavement disorder, PCBD, formerly known as complicated grief disorder. This is a pathologic state characterized by severe and persistent grief and mourning reactions. Symptoms include indefinite yearning or longing for the deceased, intense sorrow and or distress that does not improve over time, depression, detachment or isolation, persistent feelings of loneliness or emptiness, and a desire to join the deceased. Our plan of care for the elderly that are experiencing grief and loss would be to start with a baseline of labs and EKG. The reason being is that many of the people in this age group already have comorbidities which they're probably being medicated for and or can interact with some of the medications that we have planned for anxiety and or depression. Some of these comorbidities can include hypertension, heart disease, kidney disease, diabetes, just to name a few. So you want to get a baseline of labs, and this is the baseline that I've chosen: the CBC, CMP, hepatic panel, thyroid panel, urinalysis, drug screen, alcohol level, and a baseline EKG. I would also consider some vitamin levels such as a B1 or a B12, and then I would take a look at their medications to see if there was anything else that I might want to consider in the labs that I draw. The other interventions that I do pharmacologically, I would put them on an SSRI, which is first line treatment for depression. And Zoloft is one of those that are very gentle with the elderly at 50 milligrams once a day. And we would titrate up weekly to a maintenance dose of 50 to 200 milligrams. The half-life of Zoloft is 26 hours, and it takes about 2 weeks to see effectiveness. Some of the side effects that I would warn them about is nausea, headaches, sleeplessness, and diarrhea. I would also include other therapy. Although I believe pharmacological intervention will help, I do believe that the social isolation that they may be experiencing will be benefited more with having some group life reminiscent therapy, some interpersonal psychotherapy, some cognitive behavioral therapy, and to find some local senior organizations to join. There are plenty of senior organizations in my area and there are senior citizen housing that have multiple activities that they do every day. We have a Jewish community center that also participates in a lot of senior activities daily. So they have to find a place where they're with people that can understand and relate to some of the things that they're going through, and also give confidence that things will get better as time goes on. Our second specialty group is perinatal infertility. I chose to focus on depression associated with miscarriages. Miscarriages can place a huge psychological burden on the mother, father, and other family members. Approximately 20% of all pregnancies end with miscarriages, and the word miscarriage is sometimes interchanged with spontaneous abortions. These happen within the first 22 weeks of the fetus development, making it the most common obstetric complaint by women. Cost of miscarriage medical treatment for uninsured or underinsured can range from $4,000 to $9,000, with another $750 for medications. Other facts about women presenting for mental health consult after miscarriages include 53% have depression, 27% have prenatal grief, and 18% report anxiety. The DSM-5 diagnostic code would be depression due to another medical condition, and with this code, it must include either depressed mood or loss of interest or pleasure, along with 5 or more other DSM-5 criteria. And those 9 criteria include sleep disturbance, interest pleasure reduction, guilt feelings or thought of worthlessness, energy changes or fatigue, concentration or attention impairment, appetite weight changes, psychomotor disturbances, suicide thoughts, or depressed mode. The second DSM-5 diagnostic code would be grief, and that's persistent, intense grief lasting longer than expected and interfering with daily function, 6 months or more for a child or miscarriage. Treatment plan for miscarriages will focus in on the emotional and psychological needs of the mother and the rest of the family, but particularly the mother in this case. We want to acknowledge her feelings and emotions, make sure she can speak freely about feelings of guilt, shame, and blame, and let her know that she's in a safe space to talk about these things without judgment. We will provide information on miscarriages and why they occur, whether it's through pamphlets, referrals to websites, or anything that can help her to understand that it was not anything that she had done or the blame should not be on her. We give this information also to the spouse and other family members so they could too understand and support her as she goes through this traumatic event. I would give the PHQ, Patient Health Questionnaire 9 Depression Questionnaire, to see where she was in her depressive state. Provide information for support groups. We'll do labs and to get baseline information, the CBC, CMP, hepatic panel, thyroid panel, urinalysis, and urine HCG. The reason I want to do a urine HCG is because if I intend to prescribe any medication, I want to make sure it's pregnancy safe, even if whether she's pregnant now or she intends to get pregnant soon. I will prescribe the SSRI for depression or anxiety if needed. Again, I say if needed because at this point it may not be needed and it may be other methods of that we can encourage her to take part in that will help her with her current depressive state. And if I did use one, I would use Prozac 20 milligrams once a day in the morning. This is pretty pregnancy safe. It's easy to take and it has less side effects. As a half-life of Prozac is 2 to 4 days, and full effectiveness takes weeks. I would recommend cognitive behavior therapy as well as group therapy with other mothers experiencing miscarriages, just to give her the understanding that she is not alone. I would also recommend things that she could do at home, whether it's meditation, yoga, or anything that is that where she can do self-care to prepare herself in case she does want to have another child in the future, and or so that she can feel at whole and at peace with what has happened with her. Our next specialty group will be pediatric adolescents, and I chose to focus on youth experiencing homelessness. Youth who experience homelessness have a higher rate of emotional, behavioral, and mental health crises. Children that are separated from their parent have disruption in family stability and increased PTSD. Stress, depression, likelihood of substance abuse, and suicidal ideation are other factors that relate to youth experiencing homelessness. 1 in 41 school-age children experience homelessness in the United States. For children under 6, 1 in 18 experience some type of homeless situation. Now, homelessness can be anything from couch surfing, where they're staying at different places at night, to living out of cars, living in abandoned houses, living in homes that are not considered deemable to be lived in, or spending the night anywhere other than the home where their parents are. Average cost of government funding for care of one homeless child per year is $35,578. The DSM-5 diagnosis for youth experiencing homelessness, the first one would be social communication disorder. And homeless children may be facing challenges in social interactions due to their living circumstances, and SCD helps clinicians recognize communication difficulties. The other one would be persistent depressive disorder. This disorder occurs over a 2 week period continuously with one of the following: depressed mood or loss of interest. It also occurs most of the day for more days than not for at least 1 year in adolescence. The other one is social anxiety, marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. With children facing homelessness, especially in school systems, there is a stigma that is placed upon them, and that bullying becomes intolerable, whereas some of them do not continue to go to school or resort to other means of coping, such as substance abuse and or promiscuity. The treatment plan that we have for this group is baseline labs will be drawn with a urine drug test depending on the age if medication therapy is needed. I would have them do the PHQ-9 depression scale if they're at an age to understand the scale and determine the level of depression that they're currently in. I will go through cognitive behavioral therapy as well as collaboration with school counselors to understand performance in school. We would try to get family-based therapy when possible and individual therapy. And we have intervention with assigned caseworkers. If medication is needed, I would go with Lexapro for children for ages 7 and up, 10 milligrams per day for at least 2 weeks. There are some there are some organizations federally supported called McKinley-Vento that actually work with homeless children in school to get them placement, to get them clothing, make sure that they have their immunizations, and this is nationwide. So it is a federal organization that is free, but I would challenge people to find organizations within their counties and their states that could support the homeless children. Our next specialty group will be the LGBTQ community. That's lesbian, gay, bisexual, transgender, queer. Our focus will be on transgender youth. Transgender is defined as those whose gender identity does not align with their sex. Transgender people have been historically ignored and discriminated against by society and the healthcare delivery systems. According to the U.S. Centers for Disease Control and Prevention, 1.8, roughly 500,000 youth between the ages of 13 and 17 identify as transgender. 27% say that they feel unsafe at going to school, 35% are bullied at school, and 35% attempted suicide at one time or another. Hormone therapy for transgender in 2018 ranged from $72 to $8,792. Our DSM-5 code for transgender youth would be gender dysphoria. Gender dysphoria is the psychological distress that results from an incongruence between one's sex assigned at birth and one's gender identity. Though gender dysphoria often begins in childhood, some people may experience it at around puberty or much later. Multiple domains of gender affirmation include social affirmation, changing one's name and pronouns, legal affirmation, changing gender markers on one's government-issued documents, medical affirmation, puberty suppression or gender-affirming hormones, and surgical affirmation, vaginoplasty, facial fertilization surgery, breast augmentation, masculine chest reconstruction, etc. The other DSM-5 code that we could use is major depressive order, code 296. Individuals who feel down and have lost interest in the things they once enjoyed. Plan of treatment for the transgender youth would be collaboration with the primary care physician for their medication regimen, especially if they're on hormonal therapy. I would have the patient take the PHQ-9 depression screening to determine level of depression. First option of treatment would be cognitive behavior therapy because it is not only effective in children, but it also allows the patient to practice social skills. Also for consideration is for trans affirmative therapy. Group therapy in local jurisdictions would be helpful. Would only repeat or do labs if recent ones were not done at the primary doctor's office. Would recommend family therapy as much needed family support and education. And if I had to recommend a medication for depression or anxiety, a drug of choice would first be the SSRIs or the SNRIs, but it would be dependent on their current medication regimen and also their hormonal therapy. I don't want to create a bigger problem than the problems that they already have. Our next specialty group will be immigrant or migrant workers, and I chose to focus on undocumented immigrants. Undocumented immigrants in the United States face many discriminations and fears, including fear of deportation, language barrier, low socioeconomic status, lack of access to health care, and unable to qualify for Affordable Care Acts. According to the Pew Research Center, there is an estimate of 10.5 million unauthorized immigrants in the U.S. 4.6 of the U.S. workers in 2021 were unauthorized immigrants. Cost of treating uninsured, undocumented immigrants, primarily in the emergency department, is about $4.3 billion, according to the Center for Immigrant Studies. The DSM-5 diagnosis I would use is specific phobia 300.29. This is excessive fear and immediate anxiety response and avoidance of the fear trigger. And in this case, the fear is deportation or the ISIS group that at one time was taking people off of their jobs, not allowing them to go back to their families and deporting them straight to their country of origin. Symptoms must limit a person's ability to function and last at least 6 months and not be due to another mental disorder. The other one would be separation anxiety. As we know, a lot of people are seeking asylum when they come into the United States and they're running away from some harsh treatment in their own country, thus also leaving their families. And not only in that instance, when they are coming to the United States and they get here, in several cases we've heard about how they are separated from their children, their wives, and actually the mothers from their children. So that separation anxiety is unusually strong fear of anxiety separating from people they feel a strong attachment to, such as their children and their spouses. The stress associated with separation is prolonged and severe. The other one is PTSD. As we stated that they will sometimes seek asylum in the United States, that criteria is exposure to a traumatic event, either directly or indirectly, and intrusion symptoms such as flashbacks, nightmares, or distressing memories. Avoidance of reminders of the trauma such as people, places, or situations, and negative change in thoughts and moods such as guilt, shame, anger, or detachment. And I think being in that situation when you're away from your family and then you're away from the family that came with you and you feel alone and you don't speak the language and you don't know where you are, that PTSD is just a reminder of where you came from. And sometimes the situation, even though it is better, it is still isolating and it still can be dangerous and something to consider. The treatment plan for immigrant workers is it's important to establish a sense of trust with people who fall under this category because fear of deportation or separation from family members, unfavorable consequences, lack of trust for outsiders of their culture and outsiders of their religious belief, and also a huge language barrier can cause for a system of mistrust. I would first make sure that there is a language interpreter present or on an official language translation service so that they would have some comfort in being able to speak their native language. I would give recommendations for support groups that can help them adjust to the environment. Find immigration services that offer free services or referrals for healthcare and housing. And once the relationship is established and the basis of Maslow's hierarchy of needs, and that's the need for safety, food, and shelter, is met, I would then address the psychological issues. I think in these circumstances, which these are very unique circumstances, until the basic needs are met, the other needs cannot be addressed. And just for a side note, I worked in when I worked with COVID, and one of the groups that we worked were the Hispanic Latinx community. The hardest thing was getting them to trust us to get the vaccine to them for free. So when we would go to places like the pharmacy and they would ask for their ID, They believed that once they took their ID, they would keep it and then call ISIS to get them. So it was very hard to get them to feel comfortable until we established a bond of trust by constantly being there and constantly coming back. So with this patient, it would have to be a consistency of care where I'm still the same person treating them, still coming back, still encouraging, and still being a part of their day to day. Our last specialty group is ethnic minority groups. And I particularly chose African American women because, one, I'm an African American woman and I can relate to some of the things that I have put on these slides. African American women in their own culture are considered superwomen because of their projected strength, because of their resistant feelings of being vulnerable, and because many of them are the head of households and they're expected to be the caregiver of the family, and not just the immediate family, but the extended family. According to the U.S. Department of Labor in 2019 labor statistics, 78.7% of Black women were in the labor workforce, and that was the highest of any race or any gender. Majority of Black women are head of households as well as breadwinners for their families, including extended families. In 2022, African American women earned 63 cents for every dollar earned by a white man. White women earned approximately 82 cents for every dollar earned by a white man. And even though Black women represented the largest portion of the workforce, they also represented the the portion that was not paid fairly, largest portion that was not paid fairly. The DSM-5 diagnosis code that I use for this specialty group would be mixed anxiety and depressive disorder. This involves symptoms of depression and anxiety concurrently, but neither set of symptoms on its own is sufficiently severe to warrant and separate diagnosis. Diagnosis may be changed if there is presentation after evaluation of anxiety and depression symptoms. The reason I chose this one is because most Black women will not admit to being anxious or depressed because there's a system of mistrust that evolves there. And that so treatment plan for African American women definitely differs from other plans that we have for other minority groups or other specialty groups. African American women are less likely to adhere to a medication regimen for antidepressants or anti-anxiety medications and are more likely to terminate treatment for psychotherapy prematurely. They need a sister circle or a circle of trust of people that look like them, that have had the same experiences and same cultural and religious beliefs that they do, where they can gather and talk with others that have the same issues and share the same experiences. They need to establish an environment of trust. According to data from APA's Center for Workforce Study, only 4% of psychologists in the United States workforce in 2017 were Black. African American women will have difficulty establishing a trust relationship outside their own culture. I would have the patient do a PHQ-9 depression survey as well as the Depression Anxiety Stress Scale, DASS, to get an idea where they're standing, where they are at this moment with their depression. I would still encourage the use of an SSRI or SNRI if I felt that their depression was at a higher scale, that cognitive behavior therapy or therapy of any kind would not help. I initially think that therapy and or giving suggestions on how to relax and how to be more do more self-care at home can be just as effective as medication therapy, but it is on the individual patient as you get to know them, actually ask them, talk with them, and find out exactly what they will and won't do. I think having them at least admit to or adhere to being in a group therapy is better than having them do nothing at all. So it's not that I would completely avoid giving any kind of treatment here, medication wise, but I would let that be secondary to trying to establish a means of getting them to do some self care and be willing to come back for another visit. And that is the end of my presentation. All of my references are listed on the next two slides, and I hope that you got some information from it and were able to enjoy it. Again, my name is Kim Grady, and if you have any questions, please feel free to reach out. Thank you.